This is the CUNYCast, smart voices, good stories, and thought-provoking conversation from the City University of New York. I'm Rick Firstman.
Pfizer was blamed for the manufacturing process, and Pfizer responded with a statement saying that, no, we have vaccines here, they're waiting to get shipped, but no one's telling us where to ship them. So that is all evidence that things are not very well organized, and that there's some chaos going on, and we can't have that.
The new year comes at a pivotal point in the global health crisis that made 2020 a year like no other. A dangerous winter awaits, even as the first vaccines give us the shot in the arm we've waited for since last spring. The vaccines are good news, of course, but a lot of questions remain. And here's one. Is their slow distribution in the early going a sign of things to come? It's one of many questions that make this a good time to check in with Dr. Bruce Wiley of the CUNY School of Public Health and Health Policy. Dr. Lee is an MD as well as a public health researcher and a writer who's been a prominent expert in this year of COVID. He leads a national research team called PHICOR, whose modeling has been helping guide the science behind infectiousness and immunization. And his coronavirus columns at Forbes.com are among the best places to find the latest on COVID and keep a check on the latest misinformation. Welcome back to the CUNYcast, Dr. Lee. Thanks for joining me again.
Thanks for having me, Rick.
So you and I started talking about COVID at the onset 9 or 10 months ago, and you've been writing about it and been quoted widely throughout the year. So much has happened since the beginning. Obviously, so many people have died. We're now at a pivotal level. We have vaccines faster than we thought possible, but we also have a very bleak winter ahead. So broadly speaking, what does 2021 look like to you at this point?
Well, we now do have 2 vaccines that have received emergency use authorization, and they're being slowly rolled out. So that's encouraging news. But we need to keep in mind that we have to continue to do social distancing and face mask use while the vaccines are being rolled out, and potentially beyond it as well, because the vaccines alone is not going to be the magical potion, so to speak. They are important advances. There are still things that we need to figure out in terms of whether the vaccines can prevent infection, prevent people from spreading the virus and things like that. So again, there's cautious optimism, but we need to make sure that other public health measures like face mask use, social distancing remain in place. January and February could potentially be very tough months because we know that the virus is picking up in terms of transmission. There's more and more cases each day. If you look at the epidemic curve from October, it's been steadily increasing. A lot of hospitals and intensive care units are being filled with patients with COVID-19. So we have to brace ourselves for a challenging winter.
So you agree with most experts about that. But we do hear sort of different estimates of when the vaccines will be to the general public, when we're going to start being normal again. What's your sort of your best estimate of that?
So right now the vaccines are largely available to the highest priority groups. So you're seeing that a lot of healthcare professionals, especially frontline healthcare professionals, are getting the vaccines, and then people who are at much higher risk for bad COVID-19 outcomes, like people who are in nursing homes, for instance. So it's not yet available to the general public. So we have to make sure that those folks are covered first. So that's going to take a while, because if you look at the news as well as anecdotal evidence or on social media, there are many healthcare professionals that haven't gotten the vaccine yet. And they're wanting the vaccine but haven't gotten it yet. So that's going to take a while to have them covered as well. So the question is, first of all, when is the vaccine going to actually be available to the general public? That's going to take a little while. So estimates are maybe, at earliest later in the winter. Many estimates are saying, March, April, or sometime in the spring. So then after that occurs, then it's going to take a while to roll out the vaccines to everyone in the population. There were some early estimates in terms of vaccinating 10 million people a week. We have seen that the estimates of the early vaccination have the actual vaccination rates for early on has fallen below what the estimates were. So it could be that it will take longer to vaccinate the entire population, or at least the bulk of the population, than originally estimated. So then we're bringing ourselves into the summer. The summer will help in terms of reducing the transmission of the virus, because we saw this past summer there was lower transmission, most likely during the summer. So that will probably occur. So there'll be some relaxation of concern during the summer. But will we completely return to normal by the summer? That could be challenging. So we might, this might continue into the fall in terms of, having to maintain precautions and things like that. We have to remember that social distancing and face mask use can't end immediately right after vaccination. That we may need to continue that for a while. So that's the current situation.
Right. Yeah, and you mentioned the numbers so far are not what we're expecting. The federal government was telling us to expect there would be maybe 20 million people vaccinated by the end of the year, which is where we are in terms of the calendar, but not in the numbers. Looks like it will be fewer than 3 million vaccinated by this point. And the research team that you lead has worked on vaccine delivery issues for 15 years, and you warned recently in a piece for the health news site Stat about ways in which the supply chain for COVID vaccines could be hindered. So are we starting to see those mistakes, the mistakes that you wrote about in that piece, being made, and what does it portend about going forward?
Yeah, one of the concerns leading up to the vaccine rollout was that you heard a fair amount about the vaccine development. So you got information about where the vaccines were in terms of being developed and being tested, and then there's a fair amount of talk about how are you going to pay for the vaccines, the funding that's coming out of government initiatives like Operation Warp Speed to pay for the development of the vaccine, and also the actually supporting the production of the vaccine. But there was relatively little information about how the vaccines were actually going to be distributed. And we have seen many times over the past 15 years how many times vaccine distribution is overlooked, even though it's a very, very complex operation involving very complex systems. Because if you keep in mind the vaccine supply chain, which is basically the series of people, processes, locations, equipment, vehicles, etc., that take the vaccines from their point of origin, where they're manufactured, all the way down to the people. It involves many different people, many different forms of equipment, many different processes that are especially complicated because you have a vaccine like the Pfizer BioNTech vaccine that requires additional storage requirements. Those have to be kept at negative 90 degrees Fahrenheit. And so the supply chains that are out there weren't really ready to distribute these vaccines. And that you really need to keep in mind that this is a complex operation, that everyone needs to know what's going to happen. So it would be equivalent to going into, say, a major football game and not really telling all the players like what the strategy is, what the game plan is. And that's what we saw when the vaccine was getting rolled out. A lot of people were told, okay, vaccines are coming, they're going to be arriving, but people weren't clear exactly like when they would arrive and what they needed to do and what the exact status was and what the plans were, et cetera. So as a result, we've seen, for example, there was that situation over the past several weeks where states were promised a certain number of vaccines. Then those promises were cut, in many cases by 40 to 50%. A lot of the state governors were upset. Then there was a back and forth about, well, why did this happen? For a week, Pfizer was blamed for the manufacturing process, and Pfizer responded with a statement saying that, no, we have vaccines here, they're waiting to get shipped, but no one's telling us where to ship them. So that is all evidence that things are not very well organized, and that there's some chaos going on. And we can't have that, because we have to keep in mind that people at the levels of vaccination locations, they have to sacrifice other work to be ready for the vaccines. It's not as if people at vaccination locations are just waiting and idly. They have a lot of very important work to do. They have to take care of patients and do other things. So if you're telling them that the vaccines are going to be available at a certain time and they don't actually come, that has a lot of ripple effects. So we're seeing, challenges in terms of organization, in terms of communicating. Potentially, can these vaccine supply chains actually handle vaccines? We have to keep in mind that only a limited number of vaccines have already come down the pipe. What happens when we have mass vaccination? There's going to be a lot more vaccines there. And there's been other situations where, there were reports of pharmacists having to toss doses because some of the bottles were, there were issues in terms of the actual number of doses in the bottles and how that corresponded with the demand. So we're seeing a lot of the issues that we're concerned about actually coming to or actually manifesting themselves.
Is this because of the speed with which the vaccines were developed, tested, and approved?
It's an issue in terms of the planning and organization, because we have to keep in mind that we knew that these vaccines were being developed, and ever since the spring, and we knew that they were entering phase 3 clinical trials in July. So that was a fair amount of lead time to get everything ready. So yes, these vaccines are coming out and have been developed fairly quickly, but there's still a fair amount of lead time. There was at least half a year to do the planning and the communicating and all of those things.
So what does this tell us about going forward? If this situation, we're in a place where so many millions fewer people are vaccinated than we had hoped by this point. Are these logistical problems, do you see them being worked out reasonably well in the next few months so that we would be where we want to be?
Well, we need to pay a lot more attention as a society to these issues. So they're not going to work out by themselves. They're not going to work out magically. There needs to be a lot more organization, a lot more understanding of this complex system. We do have the capabilities and the knowledge and approaches to correct the situation. We do have those things. The question is, will there be a shift when it comes to the dialogue and the decision makers in saying, okay, let's really understand the complexity of this. Let's incorporate all the methods and approaches that we have available and the learnings from the past and change the system. Now, will that happen? It's not very clear because there isn't really talk of more dramatic shifts in terms of that. So the possibility is there, but we really need to change the dialogue and pay a lot more attention to vaccine distribution, vaccine supply chains, and acknowledge that these are complex systems and you really need the complex approaches to help solve these problems.
Do you have any sense that the change of administration will have a positive effect on that?
Yeah, there's that hope. And what's been encouraging is that a lot of the messaging from the new administration is that decision making will lean more heavily on science and will incorporate science more heavily. And so that's encouraging because we really need to have scientists and public health experts making these decisions and have an acknowledgement of that these are complex systems. These aren't simple things that can just use simple solutions. So that's encouraging, but we'll have to see once the new administration takes over.
Right. What do you think the new administration, what are some of the first things that you'd like to see change on January 20th overall in terms of the whole pandemic?
Well, this is one thing. So really organizing and better understanding vaccine distribution because the rollout has already occurred. So we really need to fix the system. So that's one of the first things that needs to be fixed. Secondly, we really need to fix the issues with non-pharmaceutical interventions. So the whole wearing of face masks, the whole social distancing, and all those things have heavily politicized, and that's not appropriate because those are public health interventions. So we need to have an overhaul in terms of how all these things are being viewed and who's making the decisions. So we need to restore public health experts and scientists as the decision makers. So for instance, CDC needs to take a more prominent role in terms of making the decisions and guiding the national response. So we need to remove the politicization and having political leaders make statements about a lot of these response measures. These have to come from scientists and public health experts. So that's right. The first big change, and that's going to have a trickle-down effect. So we really need to overhaul those things.
Although the political situation with sort of how it relates to the election and how, half the country, or not quite half, thinks that Biden is not a legitimate president. So you have to worry, right, about people following that leadership in terms of COVID.
Yeah, and I think the key that everyone needs to remember is we have a public health emergency. It's an ongoing public health emergency since basically early 2020. And the solution is going to be through public health and science. It's not going to be through politics. And our country has to come together to battle this common enemy. And the problem has been that some political leaders have politicized what shouldn't be politicized. And so one of the things that the new administration can do is say, okay, look, this is not about politics. This is not about partisanship. This is about the fact this virus is out there. It's a real virus. There are people who are suffering. There have been over 330,000 real deaths. What's been appalling is people have actually been arguing or claiming that those numbers are not correct or not real, and which is a shame, and it's outrageous because these are lives that have actually been taken from us, and it's affected many families and many lives, etc. So there needs to be a clear statement that these are not political partisan issues. This is a real public health issue, and that messaging has to be very clear.
Now, in the last week or two, we've been hearing about a mutated version of the virus from the UK. And we know that there have been other mutations of it, and that viruses mutate commonly. But there seems to be some alarm about this. How concerned should we be about it? And do we know if the approved vaccines and the others coming down the pike will work against this mutated version and potential other mutations?
Yes, Rick, that's a question that I'm asked quite frequently, whether these new COVID-19 coronavirus variants that have been found in the UK and South Africa will affect what's happening with the pandemic in general. So the question is whether this will affect, first of all, the spread of the COVID-19 coronavirus. Well, initial findings have suggested that this new variant is maybe 70% or up to 70% more transmissible than previously circulating variants. That's what a recent Centers for Disease Control and Prevention, or CDC, announcement stated. This suggests that this new variant is more contagious and therefore will spread more rapidly and faster across the population, which of course is not positive news. The other question is whether this new variant is going to affect the effectiveness of the vaccines that are currently out there. So it appears that these variants or the mutations in these variants have led to possibly 17 amino acid changes in the virus's proteins, including 8 in the virus's spike proteins. Now, the key here when it comes to both the Pfizer, BioNTech, and Moderna vaccines is the spike protein, because those vaccines are essentially mRNA or messenger RNA vaccines. mRNA is like a blueprint for cells to create certain proteins. So the mRNA is for the spike protein. The spike proteins are these protein spikes that appear on the surface of the COVID-19 coronavirus. So if you look at pictures of the COVID-19 coronavirus, they look like little spiky massage balls with those spike proteins on the surface of them. So what these vaccines are supposed to do, once the mRNA gets into your body and then the mRNA is gobbled up by immune cells, then your cells are supposed to use the mRNA as blueprints to produce spike proteins. And then your immune system recognizes the spike proteins or says essentially, these are not supposed to be in the body, and therefore generates an immune response to spike proteins. So as long as the spike proteins don't change significantly or substantially, then these vaccines should still work. So these variants are showing some changes in the spike protein, but it looks like so far not enough to really affect how well the Pfizer and BioNTech and Moderna vaccines will work. So for now, the vaccines appear to work against these new variants, but of course we have to continue to monitor the situation to make sure things haven't changed. So this shows the importance of making sure that the virus hasn't changed substantially, and it really points to another reason why we should do more extensive testing in our country.
Your team, your research team, which is a collaboration around the country, and you are the head of it, you've done some work in terms of the efficacy of vaccines, or how much of the population needs to be vaccinated for herd immunity. You've done a lot on that. So could you just talk about that, what you've found?
Yeah, one of the things that our flight court team has done over the past 15 years or so is we've been developing and running computer models to help with public health decision making. And one of those big areas has been helping simulate different epidemics and pandemics and different control measures. And we've done that, for instance, there in 2009 H1N1 pandemic, we were embedded in Health and Human Services to help with the national response. And similarly, during 2020, we've developed models of different locations like the United States population, for instance, and then simulate the spread of the COVID-19 coronavirus and different interventions, including different vaccines. So one of the studies that you're referring to, it was published in the American Journal of Preventive Medicine, where we looked at different types of COVID-19 vaccines that had different levels of effectiveness and worked by different mechanisms. And what would happen if we rolled out those vaccines in the U.S. population, and how that would affect the need for other things like social distancing and face mask use. So we found, first of all, that a vaccine has to have an effectiveness or an efficacy of at least 80% to slow or stop the pandemic to the degree where you don't need social distancing measures. You don't need those non-pharmaceutical interventions like social distancing and face mask use. So a vaccine needs to be at least 70 to 80%, usually more than 80% effective for that to even be a possibility. And so what's been encouraging is that these new initial COVID-19 vaccines seem to have a greater than 90% efficacy. Now, that efficacy has to be in preventing infection. So that's not completely clear with these two new vaccines, whether they can actually prevent infection. But the other finding is we found that over 70% of the population has to get vaccinated. So for us to, quote unquote, return to normal, that's a significant proportion of the population. So in other words, if only a minority of the population, only 30, 40, or 50% of the population gets vaccinated, it's not really going to slow the pandemic to the degree where we can, quote unquote, return to normal. So that's an important finding.
And the polling is somewhat positive. It's going up in terms of percentage of people who say they will be vaccinated. It was kind of low for a while, and now it's gone up. It's getting closer to that 70%. It seems to be. Do you think it's going to keep going up as the vaccine gets out there?
Yeah, I think as people get more and more used to the vaccine and there's more and more information, then hopefully there'll be more understanding of what the vaccine can do, and how it's developed and its technology, we have to keep in mind that 70% or greater coverage has to occur everywhere. So it can't just be an overall number. So if you have neighborhoods or populations or communities that have less than 70%, that means the virus will continue to spread. And so let's take New York, for example. We know that New York is made up of many different communities and different neighborhoods, and these communities can be very diverse. And if you have particular communities that are suspicious of the vaccine and don't accept the vaccine, you will have fairly low coverage levels, which means that the virus can continue to spread. So it's really, really important to remember that our country is very diverse and that everyone matters. Not just particular towns, or not just people who happen to have access to the vaccine, or people who have enough money or who are connected. Everyone needs to be protected. And that means everyone needs to be involved in the vaccine rollout, and they need to feel like that they're part of the process and part of the decision making. Because you can imagine a situation where you have a community and they look up and they say, hey, hold on a second, everyone who's appearing and talking about this vaccine, they don't look like us, or they aren't from our community. So is this a situation where, one group is trying to get another group to get vaccinated? That could raise suspicions, because there's many populations and communities that have historically been marginalized, or maybe ignored by the healthcare system, or overlooked in government decision making. You can't expect them to immediately have trust in the healthcare system if over the years they've been ignored and overlooked, or if they don't feel like they have representation when it comes to the political process. They look up and say, well, political leaders don't look like us. They aren't from our background. So we have a lot of bridges to be built to make sure that the vaccine rollout is successful.
Right. Those are very interesting and important points. You just touched on something that I've been thinking about, wondering about, in terms of the effectiveness, the efficacy in preventing infection. In these efficacy trials, of course, half the groups were given the vaccine, the other half placebo. And I didn't read anywhere about, did they track people who got the vaccine, or either one or both groups, what their behavior was? Did they wear masks? What their social interaction was, to see sort of how that plays into it. And secondly, this 90+% were people did not have symptoms of COVID. It wasn't that they got negative tests; they weren't tested, correct?
Yeah, those are definitely limitations of the trial. As you indicated, they didn't really track, or at least it isn't reported in the publications or the data, what are people doing otherwise in terms of reducing the risk of COVID-19. They may be wearing masks, they may be social distancing. We have to remember that people who enroll in a clinical trial may be quite different from your average or typical person, because these are folks that have chosen to be participants in a study for a vaccine that's still at the time experimental. So that may not be your typical person. These may be people who are more likely to be more careful in terms of not getting exposed to the virus. They are certainly people who acknowledge that the virus is real and the effects are real. And we know that across the country, there's varying situations where people may not be very careful or may be ignoring the pandemic. So the effectiveness of the vaccine may actually go down once it's rolled out to the general population, meaning the measured effectiveness. And that's typical. Typically, the measured effectiveness or efficacy in a clinical trial tends to be higher than what it is actually in the real world. There's other things happen too, like you may not be as careful with the vaccines as you are in a clinical trial. And then the other thing you mentioned is this efficacy is measured efficacy in terms of preventing COVID-19 symptoms. So it didn't necessarily measure people who are asymptomatic or have very mild symptoms or things like that. So we don't know how good the vaccines are in terms of preventing infection in the first place, or preventing the spread of the virus.
So it seems logical that some percentage of those who are in that 90% might actually just have the virus but no symptoms, and so that's fine for people who don't have no symptoms. They don't get sick, but they can still transmit it.
Yeah, that's the concern. So, as you mentioned, of the people who didn't, the 90% who didn't develop COVID-19, they still can have relatively silent infections and still could be shedding the virus and spread it to others. Now, subsequent studies will probably measure those to see if indeed the vaccines do prevent infection and prevent shedding of the virus, but at this point we don't know.
So those are some big questions that we'll wait to see. So I just wanted to wrap with the whole question about transmission, airborne versus surfaces, washing hands. I think a lot of people, myself included, first month or two, we were scrubbing down all our groceries or leaving them in bags, outside for 2 days, things like that, and that kind of faded away. We don't feel like we need to do that. So what do we know now that we didn't then?
So the key things that evolved since the start of the pandemic, one is understanding that aerosol transmission probably plays a larger role than initially thought. So it was initially thought that the COVID-19 coronavirus spreads similar to the flu. So if you look at the flu, a lot of its spread is through direct contact through respiratory droplets, and that's within 6 feet. So large respiratory droplets can't travel further than 6 feet. It's tough because they're heavier and they drop to the ground. But one of the things that has emerged is that there might be aerosol transmission where you have lighter particles, virus particles that float into the air and travel for further. And that's one of the reasons why face mask use became even more important, because how do you prevent people from spewing out these virus particles, not just the larger droplets, but the smaller particles. Now, in terms of the surface transmission, that's still a concern. So you can still contaminate a surface, and you can still then have someone touch that and then rub their face and their eyes and then still potentially catch the virus. What's been emphasized is of all the transmissions, that's probably only accounting for a smaller percentage of the transmissions, but it can still occur. And so you still want to be careful in terms of cleaning things, but we have to remember that for transmission to occur on a surface, someone has to first contaminate it, so they have to cough or breathe heavily or what have you onto the surface or touch the surface and deposit enough virus, and then you have to touch it soon enough, because over time the virus can't survive beyond maybe 1 or 2 days on the surface, so it's degrading throughout time, and then infect yourself. So those things have to happen, but we don't want to go too far the other direction. You still need to clean surfaces. You still need to decontaminate surfaces. You still need to be careful. So we want to be careful about that. Like I've heard some folks say, oh, well, now we don't need to clean surfaces. Now we don't need to be as careful. Well, I'd still be careful about it. But in a relative scheme of things, your chances of getting infected by, through the air are higher than through touching surfaces. So we have to keep in mind, I know there's been a lot of talk out there, especially on social media, how, some people are claiming things have dramatically changed since the spring in terms of our knowledge of the virus and what to do. And I don't think that's quite true. I think there's been some subtle changes. So face mask use has been more encouraged because of the reason that I mentioned with the aerosol transmission, and the fact that aerosol transmission is a concern has changed as well. But other than that, a lot of the fundamentals haven't changed. So we still want to social distance. We still want to make sure surfaces are clean. We still want to wash our hands. And it's always been known that face masks can be helpful in terms of cutting down the spread of the virus. And as you mentioned, early on in the pandemic, the focus was more on N95 masks. because people were worried that if the public starts using N95 masks, they won't be available for healthcare professionals because there was a shortage. Things would have been quite different had there been an abundance of N95 masks. But that's the reason for that messaging early on in the pandemic.
Okay, well, that was a great conversation about where we've been, where we are, and where we may be going. I got a lot of open questions, and hope for the best and do our best. And thanks so much for coming on again, and look forward to talking with you again soon.
All right, thanks, Rick. Thanks for having me again, and Happy New Year.
Same to you.